So now I invite Dr. Neena from Giridhar Eye Institute to speak on the patient with internuclear and supranuclear disorders and of ocular motility.
Thank you, Dr. Laila and AOS for this opportunity. So we've seen, as ophthalmologists, we're all familiar with the ocular movements, and Dr. Neena has wonderfully explained how we should look at the ocular movements as well as how we should diagnose diplopia. Now, we're all familiar with these kind of ocular movements, so ductions, versions, vergences. So I'm going to talk about from the neurophthalmic perspective. So we know that there are extraocular muscles and the nerves which control them. But how many of us know that there is a 3-level control of eye movements? So we have a supranuclear control of eye movements, which means we have the cortex, thalamus and cerebellum controlling the eye movements. Then we have the nuclear pathway, that is the nuclei of the 3, 4, 6 cranial nerves and the internuclear pathways. And then of course the intranuclear pathways, which constitutes the nerves and the extraocular muscles. So from this point of view, I'd like to classify the movements as fast ocular movements like saccades and slow ocular movements like pursuits or optokinetic nystagmus, vestibulo-ocular reflex and divergences, or as gaze shifting or gaze holding. So what's the purpose of all this? It's basically to focus the image onto the fovea and to keep the track of the image as the observer moves or as the target moves. So basically all eye movements and all these control is to get a good image of the object and to keep it tracked onto the fovea. So let's look at each of this. It seems complicated, but it is not so. So I'll be talking from this neurophthalmic perspective. Let's look at the gazes. So we have horizontal gazes and vertical gazes. So this all looks very complicated now, but the thing to remember is that there is a common final pathway for horizontal gaze and a common pathway for vertical gaze, but the centers are separate for horizontal gaze and separate for vertical gaze. So I'll come to that, just a bit of anatomy. So horizontal eye movement, the important thing to remember is the center is in pons, pontine tegmentum. So you look at here, you have a PPRF or paramedian pontine reticular formation and the 6th nerve nucleus, and from there the command goes to the same sided lateral rectus to the 6th nerve nucleus, and the 6th nerve nucleus, it talks to the 3rd nerve via a channel known as the medial longitudinal fasciculus, and a conjugate movement is made. So the lateral rectus on one side and the contralateral medial rectus contracts and you have a conjugate movement to one side. This is your horizontal gaze. Now how does this happen? So for that, let's look at this video. So I'm going to talk about from saccades and pursuits. So to understand what is a saccade, so this is a horizontal saccade which is generated. They're fast eye movements in which you are asked to quickly move your fixation from one object to the another across this. This is a horizontal saccade between the across the horizontal eye field. So where does the command come from? It comes from the contralateral frontal eye field. Suppose you want to look to the left. The command comes from the right frontal eye field. It crosses over, comes to the opposite PPRF and 6th nerve nucleus, and from there the 6th nerve nucleus gives command to the lateral rectus to the move, and also it also tells the opposite medial rectus to move via the MLF. So that's how a conjugate movement to the left happens through your right frontal eye field command. So this is the pathway for the horizontal saccade. And now coming to pursuits. Remember P for pursuit. So posterior parietal cortex is basically responsible for your pursuits. Ipsilateral posterior parietal cortex. Again, the horizontal gaze center is in the pons. So PPRF and 6th nerve nucleus. The same pathway via the MLF to the contralateral 3rd nerve nucleus, and you get a. So this is the pursuit happening. It's a slow tracking movement. You're following the object very slowly around the horizontal eye field. Now coming to the vertical gaze center. So vertical gaze center is different. It's in the midbrain at the thalamo-mesencephalic junction. You have 2 important nuclei. If it's difficult, forget about it. The rostral interstitial MLF and the interstitial nucleus of Cajal. And important thing is the final pathways to the cranial nerves 3 and 4, which make the upward and downward movement. So let's see some videos. Thing to remember is vertical gaze center is in the midbrain. So let's look at this video. So to initiate vertical saccades, you need firing from both frontal eye fields, because saccades are generated from the frontal eye field. So again, from both frontal eye fields fire, and the command goes to the midbrain here because it's a vertical gaze. So rostral interstitial MLF and nucleus of Cajal and the neurons of the 3rd and 4th nerve nucleus, because it's vertical eye movements, they act and you get a vertical eye movement. Now coming to the pursuits, it is similar, slow tracking movements of an object held across the vertical eye field. But remember, P for P, it comes from ipsilateral posterior parietal cortex, but the center, because it's a vertical gaze, is in the midbrain, rostral interstitial MLF and Cajal, interstitial nucleus of Cajal, again through third and fourth nerves. So there are a lot of complicated things here. You have torsional saccades also. If you want, you can look into it, but I'm not telling it to confuse you. Let's look at vergences. We always forget vergences when we examine patients. Please remember, it's very important. They are disconjugate movements in opposite directions. What does it do? It allows bifoveal fixation of an object. So accommodative vergence happens when you have a retinal blur, whereas the location disparity of an image gives you the stimulus for a fusional vergence. Now, the vergence centers are multiple, not exactly known, but you have centers in the occipital cortex area 19 and 22, in the midbrain, reticular formation, even in the pons, and the command goes to the third and sixth nerve nucleus. So there is reciprocal activation and inhibition of medial rectus and lateral rectus muscles, which allows you to converge as well as to diverge, depending on what vergence you're doing. So after that, now we come to the vestibulo-ocular reflex. Now these act like peripheral controls of the horizontal and vertical gazes. What does it mean? Simple thing is, when you move your head to one side, eyes will move to the opposite direction. This is a very primitive reflex, so that the object is always tracked. So what does it do? It keeps the image focused and holds the head steady, and it's also known as the doll's eye movement or the oculocephalic reflex. How does it happen? So when you move your head to one side, the same sided horizontal semicircular canal is stimulated, vestibular nucleus is stimulated, command goes to the opposite abducent nucleus, to the same sided lateral rectus via the MLF to the contralateral medial rectus, and a conjugate movement to the opposite side happens. So this is the basic pathway. Now coming to the optokinetic reflex, it is also an important reflex. It allows us to track a moving object with our eyes, and an intact, you need an intact optic visual pathway for this. Cerebellum has an important role. It's a master modulator. It fine-tunes all your eye movements, and you can see in this picture it has connections to all the important centers. So that's where you get abnormalities of gaze and saccades in cerebellar lesions. So let's come to some of these disorders. So basically, supranuclear lesions will produce gaze palsies, gaze deviations, saccadic pursuit disorders, vergence abnormalities, skew deviations, nystagmus, and ocular oscillations. So I won't go into all. I'll just touch upon a few. So let's look at some of these. Some of you will be asked but to look into these when you have a multi-speciality practice. So let's look at this. So this lady, you can see, has very sick. She's in the ICU, but she has a gaze. Her eyes are deviated to the left. So she has an irritative lesion of the right frontal lobe. So irritative lesion of the right frontal lobe will make the patient look towards the opposite side. So as in this case, like a seizure, or if you have a paralytic lesion of the frontal lobe, you cannot look to the opposite side, because the contralateral frontal eye field helps you to look to the opposite side. So here the patient, in this video, patient cannot look to the opposite side, or patient looks towards the lesion of the other side of the brain. So these are some, conditions in which you may be helpful in diagnosing where the lesion is. What if you have a homonymous hemianopia, which is very difficult for you to distinguish? It's a parietal lobe lesion or occipital lobe lesion. How do you distinguish? Look at the pursuits. If the ipsilateral pursuits are intact, it's unlikely to be a parietal lobe lesion, because parietal lobe is responsible for the pursuits, whereas occipital lobe lesions, it will be intact. So coming to horizontal gaze palsy, I want you to listen carefully, because this is very important to distinguish from a sixth nerve palsy. In a sixth nerve palsy, you have only the fascicular part which is involved, so you only have a abduction limitation, whereas in a horizontal gaze palsy, you have a limitation of abduction of one eye and adduction of other eye. So it can occur anywhere in the lesion of PPRF as well as the sixth nerve nucleus. So that is the key here. Both can produce a horizontal gaze palsy. And coming to INO, we know INO is due to a lesion in the medial longitudinal fasciculus. Why does this happen? Because the sixth nerve cannot talk to the third nerve. So there is loss of adduction of the involved eye. So that is typical INO. Let's look at some features. So this patient has wall-eyed binocular internuclear ophthalmoplegia. He has exotropia, and if you look, you can see carefully that his adduction in the right eye is limited with an abducting nystagmus of the left eye, and the same happens in the other eye. So some of them will have normal convergence, especially if it's a posterior INO. If it's an anterior INO, convergence may be lost. So there are so many other features. I'm not going to go into it. Important thing is, in a young patient, think about multiple sclerosis. An older patient, think about a stroke. So 1.5 syndrome, lesion of the PPRF and the MLF of same site. Then vertical gaze palsies, you have paranoids, dorsal midbrain, progressive supranuclear and monocular elevation defect. Paranoids, classical triad, you know, upgaze palsy, convergence, retraction, nystagmus and light near dissociation. And this is all because of loss of inhibitory control of this third nerve nuclei, which is present at the level of the dorsal midbrain. And here you can see that, just take a minute, you can see that this patient is not able to look up. She has upgaze palsy from hydrocephalus, and PSP is another condition which comes to you, and you may be the one who might distinguish PSP from Parkinson's, because in Parkinson's disease they don't have downgaze problems, whereas here you can see this lady has PSP, which is a very worse form of Parkinson's disease with downgaze difficulty, and this MRI will show a hummingbird sign or a Mickey Mouse sign. And Parkinson's patient also will come to you with difficulty in convergence and double vision. So this is because convergence is one of the first things to go in Parkinson's, and they have difficulty in reading, and you may give them prisms, and that may be helpful in the initial period. So how do you know whether it's a supranuclear or a nuclear lesion? Just do an oculocephalic reflex. So if the oculocephalic reflex is intact, it is supranuclear. It's because, you know, because what I've explained now. So I'm skipping all this due to lack of time. I'll just go to one last slide. So can anybody tell me what this is? So this child has a very peculiar head position. See how he is able to, when I'm giving him another toy, how he fixates or how he shifts his gaze. So when I ask him to look at a toy, see, instead of making a saccade, he puts a head thrust. This is classical oculomotor apraxia, and the parents told he's got a funny head position and he had Joubert syndrome because of the superior cerebellar peduncle molar tooth sign, superior cerebellar peduncle involvement. So the important thing is, checks, as ophthalmologists, we can always have the luxury of checking saccades, pursuits, and divergences, and remember to distinguish between nuclear, infranuclear, and supranuclear lesions. Remember that horizontal gaze center is in the pons and vertical center is in the midbrain, and vestibular ocular reflex is preserved in supranuclear lesions. And most of the supranuclear lesions don't produce diplopia unless you have a skew or asymmetric involvement. Thank you very much.
Thank you, Neena, for that excellent talk. However much you here get confused about the anatomy.